Good morning, everyone. Ohayo gozaimasu. My name is Yenny. I'm very happy to be here. Thank you for the opportunity to present the findings of my PhD research titled Expanding Access to Oral PrEP, Implementation Outcomes of a Pharmacy-Led PrEP Service Delivery Model in Malaysia. I declare that I have no conflicts of interest. So let's start with a snapshot of HIV in Malaysia. In 2023, we had over 3,000 reported new HIV diagnoses, more than 90% attributed to sexual transmission. Nearly half of these cases occurred among individuals aged 20 to 29 and were concentrated in the urban Klang Valley. The prevalence among key populations was highest among MSM. PrEP has been available in the private clinics on a self-pay basis, and it has also been offered for free in selected public clinics since 2023. Despite its proven benefits, PrEP uptake remains inadequate. Only 4,421 individuals have accessed the public program in 2024. This highlighted a need for an additional service delivery model outside of medical facilities in the private sector. Community pharmacists are trained healthcare professionals and well-suited to provide PrEP service through effective task shifting. Given that pharmacies are widely accessible, frequently visited, and often the first point of contact for health advice, it presented an opportunity to explore this model to expand PrEP access. This implementation research study was guided by the APACC framework. The research objectives were to implement the pharmacy-led PrEP services in 6 selected private pharmacies in Klang Valley and to measure these 6 implementation outcomes. Before implementation, we carried out pre-implementation work in 2 phases. We started with the exploration phase where we conducted semi-structured in-depth interviews to identify barriers and facilitators with 3 groups: key population members, PrEP prescribers, and community pharmacists. We then moved on to preparation phase where we will carry out 4 activities: the stakeholder consultation to refine the implementation plan based on the qualitative findings, online self-paced training, which showed a significant improvement in knowledge scores among the pharmacists we trained, and followed by in-person training, which was conducted as a 1-day in-person workshop covering workflow familiarization, case scenarios, and sensitization training through role-playing sessions. We also did a dry run at each pharmacy where research assistants simulated as clients to help pharmacists get ready. If you'd like to know more, you can look up the abstracts which were presented in the AIDS conference last year, available in the footnote. So for the implementation, the study, we conducted a multi-site, single-arm prospective study over 12 months at 6 private pharmacies in Klang Valley. The inclusion criteria included Malaysians aged 18 to 49, interested to use PrEP, based in Klang Valley, can understand English or Malay, and willing to pay for PrEP and lab tests as advised. In this study, we targeted low-risk individuals. The target sample size was 450. Participants were recruited using convenient sampling, and the recruitment method included social media platforms. We created an Instagram account called My PrEP Pharmacy, and through NGOs, community outreach, as well as on-site identification. So this slide shows how the pharmacy PrEP model works. First of all, the participants start by booking an appointment online with their preferred pharmacy. When the participant arrives at the pharmacy, the pharmacist assess the PrEP eligibility using digital checklists, which were integrated into an existing telemedicine platform. The pharmacist also assisted in HIV testing using oral fluid HIV self-test kit and also provide PrEP counseling. If the participant is eligible and willing to start or continue PrEP, the pharmacist will request electronic prescription from physician via telemedicine. So to enable same-day PrEP, this is because PrEP requires prescription in Malaysia and pharmacists can't prescribe PrEP. This model involves collaboration with NGO, physician, clinic provider nearby for lab testing needs and referrals. The pharmacists don't have lab testing services, but they collaborated with private labs to provide blood tests every 2 months. The participants could also test anywhere they prefer. Remote consultation with physicians was available throughout, and also there was a referral pathway in place if a participant tests reactive. So at the end of the visit, the pharmacist will dispense PrEP and schedule for the next follow-up. All participants will follow up for 7 months. At month 147, the 7-month follow-up is mainly due to time constraint. We have a PrEP experienced subgroup who self-reported continued use in the past 6 months and also a HIV negative test result within 3 months at baseline. They didn't require the first month follow-up, which was mainly to check whether they have any issues with PrEP and side effects and so on. So they will follow up 3 monthly, twice at month 3 and 6. And also there will be a routine HIV testing at every visit. This model involves real-world implementation involving out-of-pocket expenses where participants pay for PrEP at subsidized price and also lab tests as advised. In this study, baseline kidney function test within 3 months was required. So for the study instruments, the acceptability, appropriateness, and feasibility was measured using a 4-item validated tool. And then for sustainability, we measured based on the overall satisfaction level rated on a 10-point scale, willingness to recommend the service to others, as well as willingness to continue using the service at retail price. For fidelity, fidelity refers to how well the service was delivered as intended. And this is based on 8 items related to core components of service, workflow, and competencies identified during stakeholder consultation. This was adapted based on a study from Kenya, and it was rated on a 5-point scale. For the results, over the 4-month recruitment period, 354 individuals expressed interest to participate via Google form. Referral sources were mainly social media and peer referral. The exclusion was mainly due to participants having no response or change of mind. So in the end, we had enrolled 230 participants for the study. Out of the participants who enrolled, 211 attended the baseline visit, 6 withdrew, and 11 defaulted appointment. And a total of 208 participants were eligible for PrEP. 3 were not eligible due to reactive HIV test result at baseline. 1 reported hepatitis B and hypertension. And 205 initiated PrEP. 3 did not because they were not willing to. And the total active participant end of study was 157. We had a total of 3 HIV seroconversions, 1 at baseline, 1 during first month of follow-up, but yet to start taking on-demand PrEP, and 1 while on PrEP at month 4, and all 3 were linked to care within 1 to 2 weeks. So we collected participant demographics at baseline and in the post-study online survey. The median age, about 80% of participants completed the survey. The median age was 30 years. Majority were Chinese, and most were Chinese ethnicity, followed by Malay ethnicity. And most participants were male and identified as gay or bisexual. In terms of key population, most were MSM. The participants most of the participants had attained education, university-level education, had full-time employment, and most of them reported monthly income of US dollars 700 to 1,400. In terms of HIV, self-reported HIV risk behaviors in the past 6 months, at baseline, 37% reported condolences sex in the past 3 months, and 77% reported none. And in the survey, 61% reported condolences sex in the past 3 months, while 32% reported none. In our study, if the individuals reported no risk but requested for PrEP, they will still be eligible for PrEP if they meet the eligibility criteria. About half of the participants were using PrEP for the first time, which shows that a lot of PrEP-naive people were interested to access PrEP through pharmacies. 8% were first-time HIV testers, and majority preferred on-demand PrEP dosing. So in terms of adoption uptake, the initiation rate was 98%, showing strong initial uptake. In terms of retention rate, over the 7 months follow-up, in the first follow-up, it was 82%, and it declined to 72% over at the end of the follow-up period. So this shows that we will need stronger strategies to help participants retain in the study for the follow-up. So for the overall retention rate, we calculated based on participants who completed the survey. The median was 100%. 78% of these participants achieved 100% retention rate, meaning that they attended all their intended follow-ups. So the factors associated with overall retention rate were age and history of HIV testing. Older age and participants with prior HIV testing experience were associated with higher retention. And as for acceptability, appropriateness, and feasibility, the mean score ranged from 4.76 to 4.81 out of 5. Highest rating was for acceptability. And then for fidelity, the overall mean score was 4.76 out of 5, a respectful interaction received the highest rating. In terms of sustainability, the overall satisfaction was 9.39 out of 10. 98% of participants were willing to recommend the service to others. 82% were willing to continue using the service at retail price, citing reasons such as accessibility, convenience, affordability, and privacy. 17% were not willing to continue, citing reasons such as cost, stopping PrEP due to sexual inactivity, and location. We identified several key lessons learned from the implementation. At the client level, there was low reach among other key populations, such as people who inject drugs, sex workers, and trans people. And this highlighted that we would need more targeted recruitment strategies to get more key populations. And there was delay in getting lab tests done. This was quite common because due to participants' busy schedules. So it is very important that we provide more affordable lab test options and packages and ensure close follow-up so that we make sure that the participants get their lab tests done. At the provider level, we realized that it was crucial to ensure availability of physicians for clinical advice during extended pharmacy hours. There was high turnover among community pharmacies, which required training to new staff, both online and hands-on training. And we also realized that it's important to provide training beyond PrEP, particularly on PrEP, hepatitis B and C, and other STIs. In conclusion, the pharmacy-like PrEP services demonstrated implementation effectiveness in terms of adoption, acceptability, appropriateness, feasibility, fidelity, as well as indication of sustainability. This shows that it could be a promising additional access point for PrEP in Klang Valley alongside clinic-based PrEP service and could support broader scale across Malaysia. So our next step is to engage Ministry of Health stakeholders to discuss potential for scale-up. I'm incredibly grateful to all funders, supervisors, research assistants, collaborators, and all participants who supported and contributed to this research. That's the end of our presentation. Thank you.